Well, good evening, and thank you for joining me. My name is Dr. David Rubin. I am the chief of the section of gastroenterology at the University of Chicago, and I specialize in taking care of patients who have inflammatory bowel disease. I'm really delighted that you've chosen to learn a bit more about ulcerative colitis tonight, and I'm pleased that CME Outfitters has put together this wonderful program for you. I'm looking forward to your questions, and I hope that you'll be taking notes throughout the night. But this program and other parts of it will be available to you on the internet through a website that I will share with you later. The title of our program is called New Guidelines in Ulcerative Colitis, Why Should I Care? And it reflects the updates we've made in treating patients with ulcerative colitis. There, in fact, have been a number of significant improvements in the way we diagnose and treat people who have this condition, and I'm delighted to share them with you tonight, as well as some of the newer guidelines that have been published and recommended to my colleagues who take care of patients like you. Ulcerative colitis is a chronic condition. That means that it lasts for almost a lifetime or for your entire lifetime. It is most often diagnosed in people between ages 15 and 30, but very importantly, some people are older when they're diagnosed with ulcerative colitis. The cause of ulcerative colitis is not known, but it is characterized predominantly by inflammation of the large intestine. Your large intestine consists of the rectum, which is the last 6 or 8 inches of it, and the colon, which is the remaining part of the large intestine. Your anal canal and your appendix are also part of the large intestine, but they are not involved in the condition known as ulcerative colitis. The inflammation in ulcerative colitis continues from the rectum up into the colon and is in a continuous fashion that may involve just the rectum, where we call it proctitis, or parts of the colon, where we call it proctosigmoiditis, where it involves the sigmoid colon, or the left part of the abdominal cavity in the left colon, where we call it left-sided colitis, or the entire colon may be involved, where we call it extensive or pancolitis. The extent of colitis and what causes it is not really understood, but we recognize that different people have different extents of this condition. The main symptoms of ulcerative colitis are urgency to go to the bathroom and bloody bowel movements. Because this condition is chronic and can go on for quite a while, some patients live with these symptoms before they're diagnosed and are quite nervous about what it might be. The condition is also characterized by what we call relapsing and remitting features. That means that it is active at times and gives people lots of symptoms, and at other times it's in remission or quiet, and patients may feel completely back to their usual self. Of course, our treatment goals are to get people feeling back to their usual self and have that last as long as possible. There are many different treatments available for ulcerative colitis, and even though we don't know the cause, we've gotten much better at monitoring the condition as well as treating it to control it. Now, I have some representative images of what ulcerative colitis can look like for you here. All the way on the left is what a normal colon looks like when we use a scope like a colonoscope to look inside the bowel. You can see the normal blood vessels and the shiny appearance of a healthy bowel. The different degrees of inflammation appear as you look towards the right, from mild to moderate to severe. And the amount of inflammation, not surprisingly, will dictate how many symptoms our patients have or how sick they might become. Different patients have different degrees of inflammation. So just to summarize, we don't know the cause of this condition. Many patients have different extents of inflammation of their large intestine, and there's also different degrees of inflammation that may occur. Patients who have inflammatory bowel disease are not necessarily aware that there are actual guidelines for managing their condition. And in fact, CME Outfitters convened a panel of patients and recorded some representative quotes from them. So let's hear what patients had to say about whether they knew whether there were guidelines for managing inflammatory bowel disease.
A lot of IBD patients are very confused, and there's a lot of misinformation on the internet.
I don't think that patients are aware of clinical guidelines very much at all.
So let me teach you what guidelines are and what they're not, and also bring you up to speed. In general, guidelines have been published for professional healthcare providers like physicians and advanced practice providers and for our nursing colleagues. But it's very important to understand that, of course, patients should be aware of what these guidelines say. My hope with tonight's program is to educate you about the guidelines so that you can have an informed discussion with your healthcare team about your treatment options. So let's review a couple details about what practice guidelines are and how they are created. Guidelines are written by experts in the field. I'm going to share with you two recently published guidelines related to ulcerative colitis. They contain recommendations for clinicians about patient care. Their recommendations are based on evidence as performed in clinical research studies. Sometimes recommendations are based on the best opinions of the experts when evidence isn't available. Guidelines are published by our societies in most cases, and in the case of the two guidelines I'm sharing, they were published by the two largest GI societies in the United States, the American College of Gastroenterology and the American Gastroenterological Association. These two societies have members who are professional medical and healthcare providers. These societies also publish these guidelines to advance the field, but there have not been in the United States patient-related summaries of these guidelines, which is why this program is so important. There are some limitations to guidelines. First, they may become out of date very quickly. As soon as we publish them, there may be an advance in the field or new therapies. And of course, we all want that for the field. We're looking for cures of colitis and the other inflammatory bowel conditions. But in the meantime, as new treatments become available and new scientific evidence emerges, the guidelines may become out of date. So it's always important to know when they were published and what might have changed since they were published. And I'll even be mentioning that briefly tonight. Secondly, guidelines are just meant to give us guidance. They don't necessarily apply to all patients. And one of the messages about ulcerative colitis and Crohn's is that every patient is different, and recognizing what your condition may involve and how you may be treated is up to you and your healthcare team to discuss and understand. The guidelines may give you some ideas and help provide evidence to back up certain treatment decisions, but they are by no means meant to fit every single situation. And lastly, as much as we'd like the guidelines to influence how insurance companies and other payers provide support and approve the payment of different treatment strategies, sometimes the guidelines aren't known by our payers or are just ignored by the payers because the evidence isn't strong enough, or perhaps the recommendation is too expensive. That's a whole other topic that we can talk about on another broadcast. When we look at guidelines, they use evidence that has been published, and there are different levels of evidence. The lowest level of evidence are the opinions of experts when there's no research to back up those opinions. The opinions may be formed by experts who are very experienced, but without any clinical scientific studies to back up those opinions, that's why this is considered the lowest level of evidence. They may be included in guidelines, but are noted as such. Secondly, would be cases that are reported, individual cases or case series of multiple patients who have similar disease characteristics or responses to new therapies or different uses of existing therapies may be included, and that's the next level of evidence. A higher level of evidence than the one that the Food and Drug Administration asks for before drugs get approved for their availability and use is a randomized clinical trial. And a randomized trial in which both the investigator and the patient are blinded as to whether they're receiving one treatment or another is the highest level of scientific evidence. So having randomized trials that are blinded that demonstrate the benefit of one treatment over another is a higher level of evidence. And when there have been multiple randomized trials that all demonstrate the same result, that's the highest level of evidence that factors into a guideline. So as I summarize the two major guidelines during this program, I want you to keep in mind that there are different levels of evidence for the different types of recommendation. It's impossible for me to go through all the recommendations of these two guidelines tonight, but I do want you to understand the main principles and some of the general thoughts that are that went into these guidelines and that you should know when you're talking to your healthcare team. There are many similarities between the American College of Gastro guideline on the left, which I was part of, and the AGA, or the American Gastroenterological Association guideline on the right. There are many thoughtful experts who contributed. There was peer review by other experts, and overall the committees in both of these societies also review these guidelines before they are published. So there's a multi-step process that leads to these guidelines. Now, what's new in the 2019 ulcerative colitis guidelines? Well, there have been a significant number of advances in our field that are worth mentioning, and what I will be driving home this evening. The first one is a shift from reactive management of flares to a proactive monitoring and prevention approach to preventing flares and preventing bad outcomes from colitis. In the past, management of ulcerative colitis was very much focused on symptom management and treating patients based on how they presented to us, rather than trying to get ahead of the disease to know when a flare may be starting before a patient even feels them, and certainly before the patient has a consequence or bad outcome. The second major shift in the way we think about things is the separation of inflammatory activity from prognosis, or what we call severity. Activity is how sick a patient feels at the time they're being evaluated, how much inflammation there is. Severity has to do with what might happen over time, like what is the likelihood the patient will need steroids or will be hospitalized or might have surgery from their colitis. Another major advance in the field is now the understanding, appreciation, and the ability to heal the bowel, and that has become now a target of our management. So in addition to wanting to make sure people feel better, we're also focused on healing the bowel, which we know is associated with better outcomes. And I'll talk more about this in a few minutes. There have been multiple new therapies approved since the last set of guidelines were published by the societies, and we'll be talking more about these new therapies tonight, and I'll go through those in more detail coming up. We also have advanced the field in that we don't always need to do colonoscopies anymore. I know everyone's happy to hear that. In order to assess how much inflammation is in the bowel, we are now appreciating and using stool tests as markers of inflammation in specific situations. And we'll talk more about that as well in this program. And lastly, there's a new treatment for infections of the colon. The infection that we know is of significance and very important to look for and treat in ulcerative colitis and in Crohn's disease is called Clostridioides difficile. It used to be called Clostridium difficile, or C. diff for short. And we now treat this with vancomycin instead of some of the older treatments that had been used previously. The goals of management for ulcerative colitis are very important to understand. If you have ulcerative colitis, I want you to think carefully about where you might be in these goals and whether you're achieving them. The first goal is to make sure we're clarifying the disease activity and understanding the prognosis or severity. That includes knowing how much of the bowel is involved and what the overall risk for needing surgery might be. That helps us choose our therapies, as we'll be spending more time talking about tonight. The second goal is to induce remission. And the term induction of remission means turning off the disease or making the patient feel better. We want this to happen as quickly as possible for obvious reasons. We also distinguish between clinical remission, which I will define for you in a moment, and healing of the bowel, which together, clinical remission, feeling better, and healing of the bowel is what we call complete remission. The next goal is prevention of relapse. So once we successfully induce remission, we want the disease to stay away forever. That's our goal, at least. And we sometimes call this goal maintenance. But the goal of maintenance is to prevent relapse. It's not to be taking active therapy because you still have active disease. It's about preventing relapse. And one of the major features of prevention of relapse in the maintenance phase is to do so without the use of steroids, which we know have some of the worst outcomes in colitis. And the last goal, which comes after we've successfully achieved the other ones, is the prevention of disease and drug-related complications, like infections or hospitalization or surgery or the development of cancer of the bowel. And we'll talk more about these tonight. So when we talk about remission, of course, from a medical point of view, we might talk about the bowel being healed or the number of bowel movements, but actually we recognize that for patients, remission has a very different definition. It really has more to do with how you're functioning and things you want to do in life. So let's see what one of our representative patients said during our panel discussion.
Remission looks like being able to live my life fully without suffering from IBD, without putting things aside. I have activities that I can't participate in just from the symptoms and the pain from IBD. I have had to sit out from things, had to leave work early because of my symptoms. So remission to me is not having to do things like that where my life is impacted in a negative way.
So you obviously hear from this patient how much remission means functioning, doing all the things that are important in life. And I completely understand that. And that's what we're trying to achieve for our patients. And for some patients, getting back to their normal life activities, taking care of family, going to school, getting to work, are different, and we have to think carefully about what would be most important for them as we try to choose our treatment options. Now, there are different levels of ulcerative colitis activity. The first column in this table, that is from the ACG guidelines, summarizes some of the different features of disease activity: number of stools, whether there's blood in the stools, whether the patient has urgency, meaning they have to run to the bathroom, the blood count, markers of inflammation, and also how the bowel looks if we use a scope. You can see in the second column how we define remission, which means the patient is both having formed stools without any blood or urgency, but also all the inflammatory markers, labs, and the endoscopic appearance of the bowel is normal. Then we go into mild, moderate to severe, and fulminant colitis, where, as you would expect, the number of bowel movements goes up, the number of times that a patient sees blood in their stool increases, the amount of urgency they experience is increased, and the blood count may drop, the inflammatory markers are elevated, and the way the bowel looks, like those pictures I showed you already, starts to demonstrate more and more inflammation and more severe ulcers. So when a physician or your healthcare provider is looking at how to choose your treatments, the very first thing they need to do is define how active the disease may be. And you'll notice that the first few rows here are focused on your symptoms, and the bottom rows are all focused on other objective measures of what's going on with your disease. And that's a very important composite. Now, this table summarizes how you should think about prognosis. This is based on a number of different studies and is included in our guidelines, as well as what are called care pathways related to colitis. And this is based on what factors increase the risk that somebody with colitis might end up needing surgery, which we recognize nobody wants to have unless they need it. The factors associated with an increased risk for surgery include being diagnosed at a younger age. For specific reasons that we don't always understand, people who are diagnosed with colitis at a younger age tend to have a more aggressive colitis. Having extensive colitis, meaning more of that large intestine is inflamed, puts you at a higher risk. Having more severe inflammation when you look with the scope, like those pictures I showed you. Being in the hospital or needing hospitalization for the colitis increases the risk. So does having elevated inflammatory markers or having a low albumin, which is a protein in the blood that's usually a marker of your nutrition and health, but can be low when people are sick, and also when the colon is actually leaking protein, which is what happens when it's very inflamed. So we can put all these together with a variety of other ones that we've also learned about and understand what the prognosis might be. So of course we want our patient to have mild or no activity of their colitis, but we also have to keep in mind what is their overall risk for surgery later, so we can define how to follow them, how to monitor them more carefully, how to choose the right maintenance therapies, and what to do as soon as the earliest sign of a relapse occurs. So now I just want to remind you that in a little bit, I'm going to be answering some of your questions from home. You can email them to the address you see here, questions@cmeoutfitters.com, or you can even tweet them. We have people manning Twitter right now using the hashtag #TakeChargeOfUC, and we'll be collecting all those, and I'll come back to that. So let's talk a little bit more about controlling symptoms and understanding how to heal the bowel and why the two must be considered together. So first, let's see if patients in our panel had something to say about the difference between just symptom control and healing of the bowel. We have a couple of nice quotes.
For me, my clinicians have always explained both the mucosal healing of the intestine as well as symptom control.
No, I have never actually had that compared by a doctor. We've actually never discussed healing. Pretty much always a discussion on how to keep it at bay, how to keep it under control.
So you see that, not surprisingly, there's a distinction here. As I mentioned, the older way people managed colitis was really focused on just addressing symptoms, and if the patient didn't call or complain further, we were hopeful that they were doing well. And we've learned that that's not sufficient. And let me explain a little bit more to you. First of all, clinical remission, which is how your symptoms are feeling, is a very important part of UC, obviously. It's what makes people feel awful, and when we get people into remission, we know that they're feeling better. It means the following 5 things: formed stool, no blood, no urgency, sleeping through the night without having a bowel movement that wakes you up, and able to pass gas without fear of leaking. The last one is really a sensitive marker to show that the rectum, that lower part of your large intestine, has healed, and it's a very important question. Achieving clinical remission, answering these 5 questions the right way, is directly related to your quality of life. You're not surprised by this. If you're a patient out there, you know this. And I often tell people who don't have colitis that they take their rectum for granted until it's not working properly. So this is obviously very important, and it's the first part of our goal, as I've mentioned, in terms of getting people well. What we've learned, of course, is that clinical remission is necessary to get our patients feeling better, but it isn't sufficient for control of the disease itself. Why is that? Well, there's a few things to keep in mind. Up to 50% of people who are in clinical remission, feeling fine, have persistent inflammation if you look with the scope. That may be a surprise to you, or maybe it's not if you've had a colonoscopy when you were feeling well, and we're told that to your surprise there's still some inflammation. This is inflammation that persists, and therefore it also increases your risk of relapse. We know that one of the biggest fears for patients who live with IBD is the risk of a relapse that's going to wreck an important moment in your life, or come out of the blue and affect the way you're able to function in other ways. That fear and that lack of control is something that is a very important feature of these diseases. We've also learned now that if the bowel is healed, you are more likely to stay in remission, you are more likely to have the disease remain quiet, and you're more likely to continue functioning at your highest levels. Therefore, we've learned that if we push the patient beyond just their symptoms, but also to help the bowel heal, to normalize their labs, we can also provide them with the reassurance that within the next year at least, they're going to continue doing well. That amount of control in your life is such an important feature of colitis, and that's one of the reasons why we've moved forward in this regard. You may be wondering, though, how do I get my bowel to heal? Well, there's a nice study that was done at the University of California in San Diego, in which they were scoping patients who had colitis, even when they were feeling well, and they noticed that these patients who had inflammation could have their treatments adjusted and, in fact, then achieve healing. Most often, all they needed was an increased dose of their existing therapy in order to get their bowel to heal. They didn't always have to jump to new treatments and add other therapies and go through that entire discussion. So it's important to recognize that you can heal your bowel if you take the medicines you're already getting and if we optimize the existing therapies. Sometimes, yes, we do need to increase or change the medicines, but many times that's not necessary. So optimizing what you're currently receiving and making sure that we get beyond just symptom control to a healed bowel is very important. A reminder that we're accepting all your questions, and we'll be going to those after the next section. So let's talk about treatments for ulcerative colitis. That's obviously what people want to know a lot about, and we've made some great advances in. There are a number of available therapies for ulcerative colitis, and there are more coming. These are the therapies that are in the guidelines that I'm summarizing, and I'm going to go through them briefly right now. And I want to note that we're using trade names of some of these therapies so you know which therapies we're talking about. At other parts of the presentation in a few minutes, I'll be reverting back to their generic or their compound names. So let's start with the aminosalicylates, the first one here. Those are the 5-ASA therapies. These are not immune suppressive. They're actually a derivative of willow tree bark, and they're related to aspirin, but they don't cause bleeding or affect your platelets. They're used as anti-inflammatories in the bowel and are approved and available for treatment of ulcerative colitis. The types of 5-ASA therapies, you may know the names mesalamine or Asacol or Delzacol or Colazol or Lialda, sulfasalazine, Pentasa, Rowasa, or Canasa. You'll notice that many of them have the ASA in the name. These therapies have been around for a very long time. The second therapy that we would talk about is steroids, and I'm sure that most of you have heard of steroids, and unfortunately most of you may have been on them. There are several different types of steroids available, including prednisone and another steroid called budesonide. Budesonide is unique because it is released and works predominantly on the lining of the bowel, but when it gets into the bloodstream, it's immediately cleared out of the system, so it doesn't have the side effects that prednisone does. Then we have our older drug called thiopurines, which include azathioprine and 6-MP. You may know them by the names Imuran or Purinethol. These are oral therapies that we used to use more often, but are still available and in the guidelines for treating ulcerative colitis. There are 3 classes of biological therapies. A biological therapy is a therapy that's made from cells in culture, and they're proteins. And they're proteins that are designed to target a specific part of the immune system. I know that the term biological therapy is sometimes scary, in part because of confusion about what they actually do, but I want to try to summarize briefly for you. The oldest biological therapy we have in ulcerative colitis and in Crohn's disease is in a class called the anti-TNF therapies. TNF is an inflammatory protein in our body, and the first one that was approved was a drug called infliximab with the trade name Remicade. And there are now several biosimilars to infliximab that are available in the U.S. market. One is called Inflectra, the other one's called Renflexis. They're all the same, the infliximab type of biological therapy. There are 2 other anti-TNFs available for ulcerative colitis, adalimumab, which you know as Humira, and golimumab, which you may have heard of as Simponi, or some people call it Simponi. The second class of biological therapies is the anti-integrin therapy. There's only one available for ulcerative colitis, vedolizumab, which is trade name Entyvio. An anti-integrin therapy is a biologic that actually blocks white blood cells from migrating out of blood vessels into the bowel, and it's selective just for those white blood cells that are trying to go to your gut. So it works only on the bowel and the intestinal system and not on the rest of your immune system. The third class of biological therapies, and the newest one approved for ulcerative colitis, so new that it didn't make it into the ACG guidelines because it just got approved a couple weeks ago, is called ustekinumab or Stelara. This is a biological therapy that targets 2 other inflammatory proteins called IL-12 and IL-23. What we believe happens with ustekinumab is that it only affects the proteins that are elevated where you have inflammation. So a little differently in that it doesn't suppress the entire immune system, but it works where there's inflammation, which makes it a targeted therapy as well. So I hope you understand when I talk about a biological therapy, we're talking about a protein that's derived from a cell line that targets a part of your immune system. There's not a big mystery to that otherwise. The reason biological therapies are given as injections or infusions is because the molecules themselves are too big to be absorbed through your small bowel as oral therapies, and because they're proteins, they would get digested in your stomach, just like your food. So they're delivered differently as injection or infusion. That's just to get the drug into your system. There's nothing magic about that otherwise. Now, we also have a newer therapy, which is what we call a novel small molecule. We call it a novel small molecule because it's new, but the small molecule part of it means that it's small enough that it gets absorbed into your bloodstream through your small intestine, just like the oral therapy of prednisone or 5-ASA mesalamine type therapies. This new small molecule is called tofacitinib, or brand named Xeljanz, and this drug was approved last year. Now, tofacitinib inhibits an enzyme related to activating white blood cells. So when this drug is in the bloodstream, it turns off inflammation by blocking an enzyme related to how our immune cells are turned on. That's how that works. And lastly, one of our treatments for ulcerative colitis that is still necessary and very effective is surgery. And we recognize that no one wants surgery unless they must need it. And we're not going to talk in great detail about surgery tonight, but it's important to always know that surgery is available. There have been different ways people have talked about positioning these therapies, and unfortunately, I can't tell you that there's a specific way the therapy should be sequenced in everyone. But there are some smart ways that we can be positioning these therapies in individual patients. You see here what is represented on the left, which is a red arrow that says, depending on how sick the patient is at presentation, is how you might choose induction therapy, what's going to get the patient into remission. You'll also notice that on the right there is a staircase. The solid lines of the treads of the stair is meant to represent an induction treatment. And one of the principles of management is based on whatever induction treatment is used, we then choose the maintenance therapy to prevent future relapses. So for example, on the very first stair is the 5-ASA therapies, the aminosalicylates. They are very effective for induction of remission of mild or moderate colitis, and if they do their job there, they're also used for maintenance. When patients need steroids, which is the second step there, that often tells us that they're going to need to go up the stairs for a therapy that will keep them off steroids going forward. And you can see all the other treatments that I've already mentioned briefly listed there and stacked on top of each other. And that's in part because we don't quite have the markers necessary to know always which therapy we might use first. One of the ways we choose therapies is also based on whether or not the patient has extra-intestinal symptoms or problems, the most common of which would be joint pain. And another way we choose our therapies is based on the patient's lifestyle and whether or not they choose or need to take a therapy that can travel with them for work, or whether they're able to take certain therapies orally or use injections because they need to be able to get to school and do other things. And sometimes we choose therapies because we have better evidence for more severe cases of colitis. So you can understand how complex this is, and I certainly appreciate that in your own discussions with your healthcare team. But I'll try to put this in context in the next few slides. I want to address why we use immune therapy for colitis and for Crohn's disease, because this is often misunderstood. What we've come to realize without knowing the cause of IBD is that what we're observing is an overactive immune response. The immune system of your gut is very complicated, and it's there to protect you. So if you get food poisoning, it becomes activated to try to get rid of whatever is driving the food poisoning. In the situation with IBD, the inflammation is being continuously driven either by something we haven't yet discovered despite years of research, or because you're missing the off switch or something to regulate and turn off the immune system so it can go back to a resting state. So we use immune therapies to treat colitis and Crohn's disease to try and turn down the immune system long enough so your body can take over, heal itself, and get back to its resting state. So our goal is not to immune suppress you. Our goal is to modify your immune response long enough so we can get you back where you need to be, which is why we're trying to figure out ways that we can use stronger therapy to put you into remission and consider reducing our dosing or other things in the maintenance phase of treatment. There are some general principles of treatment for IBD. The first one, of course, is we want you to feel better as quickly as possible, symptom resolution. The second one is to make sure that in addition to that, we're controlling the disease, as I've mentioned, which means getting you to a healed bowel and normal labs. And that means using objective measures like blood tests, stool tests, and scopes. The third goal is developing a customized treatment plan. This has to do with knowing how much of your disease you have, whether you're having more urgency and needs more rectal type therapies, what your individual prognosis and severity may be, and other features about your disease, like does it flare seasonally? Are there times in the year that we should be proactive and modify your treatment in anticipation of a fall flare or a spring flare? And I have many patients where we've started to think carefully and give them a adjusted treatment strategy in anticipation of their seasonal flares. And what do you do when you start to relapse? How soon can we get it under control and do something to change the natural history? The next parts of treatment of IBD include, of course, choosing our therapies. And I've mentioned to you several times now that it's based on how sick the patient is at the time, as well as what their prognosis might be. The general principles are to use our non-immune therapies first when we can, to use organ-selective treatments like that budesonide steroid I mentioned to you, or some of the biological therapies that are targeting parts of the inflammatory pathway, but not the whole body, when possible. And we want to optimize our first therapy. Whenever we need to adjust dosing, we try to do so before we get to another treatment. And of course, we don't want to use steroids longer than a couple months at the most and get patients off of them quickly. We then choose our maintenance therapy based on severity of disease and based on our choice of induction therapy. And then lastly, and very importantly, after we achieve all this, we need to monitor. Chronic diseases tend to drift away from control, and this happens for a variety of reasons. And so monitoring, even when you're feeling well, especially when you're feeling well, is a critical part of what we do. And lastly, prevention is the key to good health. That means vaccination for preventable illnesses like the flu or pneumonia or shingles. It means cancer prevention, which we'll talk a little bit about, and seeing your doctor regularly. So I'm just going to summarize briefly a couple of the recommendations regarding the different activities and severities of colitis. Both the ACG and the AGA have similar recommendations for mild or moderate colitis. They start with 5-ASA therapy that can be delivered either orally and rectally. We know that when you combine oral with rectal therapy, whether it's a suppository or an enema, you feel better faster. Getting the rectum to heal is key. That doesn't mean you stay on the rectal therapy. We know that's not convenient, but that'll get you feeling better quicker. We also know that in milder disease, we shouldn't use steroids unless we really need them. Unfortunately, they are often prescribed early because we want patients to feel better quickly. But we should start with 5-ASA therapies and focus on them as long as we can. Notice that this is again for mild or moderate colitis. If you have severe colitis, these therapies don't work very well, and we need to move on. In the moderate or severe colitis patient, we can break this into induction and maintenance recommendations. And I recognize that there's a lot of information here. The first one is that steroids are often needed in the early part of treating moderate or severe colitis. The second is to recognize that when we can, we should use that budesonide steroid before we give prednisone or other systemic types of steroids. Our biological therapies I've mentioned to you are mentioned specifically in the guidelines as appropriate options for induction of severe or moderate UC, as is tofacitinib, the Xeljanz therapy, but its label has recently been adjusted so that it needs to be given only after a patient has already tried an anti-TNF biological therapy. And if a patient's not responding to an anti-TNF, they can go to the vedolizumab, which is Entyvio. They can go to the new therapy, ustekinumab, which is called Stelara, or they can go to Xeljanz. So there's a variety of different things to consider. One more point in the guidelines, based on available evidence, is that if a patient's treated with infliximab, which again is Remicade, Inflectra, or Renflexis, it's recommended that they do so in combination with ethiopurine. That would be 6-MP or azathioprine. Those two drugs together work better than either one alone. Now that is presumed to be true for Humira and Simponi, but that hasn't been shown with the strongest level of evidence yet. It does not seem to be true for the other biological therapies. So combining those therapies with others doesn't seem to be needed. For maintenance, we don't use systemic steroids. You should not be on steroids during your maintenance plan. If you're stuck on steroids, something we call steroid dependence, meaning every time you come down on your steroids, you have a relapse of your symptoms, then you probably need an adjustment of your therapy so that you can get to a place where your steroids can be safely removed. Sometimes we need to confirm that the bowel is healed to know that the steroids can come off. And sometimes patients have some symptoms and their bowel is already healed, and we're just getting confused and they're staying on steroids when they really don't need to. So this is a really important point you should be carefully considering and discussing with your healthcare provider. Thiopurines can be used as maintenance. That's the 6-MP and azathioprine. And the biological therapies, as we've already talked about, as well as the novel small molecule tofacitinib, can all be used in maintenance. So again, remember what I taught you. Induction is turning off the inflammation and getting the patient to feel better as quickly as possible. Maintenance is about prevention of relapse. If you're in remission and you skip a dose of your medicine, you're still going to be in remission. The longer you're off medicine or using the wrong dose of your medicine, the more likely you are to relapse. So we try to use what is proven based on evidence, the lowest dose of an effective therapy to keep you in remission. And we're working very hard to figure out other ways to do this in the future. So now you're finally in remission, you're in maintenance phase. Now what? This is called monitoring, and that's a major advance in our field. In the past, monitoring just meant call me if you're having trouble. Now we're actually much more proactive. That means seeing your healthcare provider on a regular basis, doing some routine tests, including blood and maybe even stool markers to know that you're in remission. I tell patients it's a little bit like diabetes, where we measure blood sugars on a regular basis and a hemoglobin A1C to know how well the diabetes is under control. Checking the stool to make sure that the disease is under control, routine scopes when appropriate, and blood tests are all part of monitoring the disease and making sure you stay well. In addition, having these healthy visits with your team enables us to talk to you about vitamin D and about diet and exercise, and to answer other questions you may have, and to update you on things like the new guidelines or new treatments that have come out. It's a very important thing to do. So when we ask our panel, we realize that most patients haven't heard anything at all about markers to monitor the disease. Let's hear this quote.
When I call and I am having any type of symptoms, she will order labs, and I know that she is looking for specific markers. I never have discussions with her about what the markers are specifically that she is looking for. I wish that I did have a better idea of what it is in the labs that she is trying to get.
So I'm very excited to share with you that there are some at-home tests that are going to be available in the near future that will help us monitor your disease without you always having to come to the physician's office or go to a lab. We're hopeful that this will change the way we think about these conditions and empower our patients to know what's going on and when they should be activating their healthcare team to help them intervene and prevent more significant poor outcomes. Now, I have a couple things to address that always come up in questions, and I want to try to do so briefly right now. The first question we often get is, why does a therapy stop working? You finally get on a drug after you've thought about all these complicated things that you heard in this program, and then that treatment doesn't work after a while. Well, there are some different reasons that we consider and that you should know about. The first one is that, remember, we don't know the cause of colitis, unfortunately, and therefore the body is still trying to react to whatever it thinks it's reacting to. And the human body is quite amazing and redundant, so it looks for a new pathway of inflammation. So if we pick one target, sometimes the body then will find a new pathway and work right around our targeted therapy. The second is that you might develop an infection, even when you haven't been exposed to anything obvious. There is an infection that can occur with colitis and make you go out of remission. The third is that for biological therapies, especially the anti-TNF therapies, there's a risk that your body can develop antibodies against the anti-TNF therapy, just like you would if you got a vaccine. You have an immune response that ends up neutralizing the therapy, and therefore it doesn't work anymore. And of course, the fourth is that the patient stops their therapy. I often remind patients that they are doing well in most cases because of the treatment that's preventing relapse, not in spite of it. And we have some active studies going on now about how we might thoughtfully reduce or discontinue certain therapies and monitor them carefully. But it has to be done under supervision and very thoughtfully based on your risk of relapse and your overall risks. Now, what do we do if your medicine stops working? Well, the first thing is to confirm inflammation. Sometimes people have symptoms, but they're actually not due to a relapse of their disease, and that's very important. The second is to make sure there's not an infection. We always look for C. diff, the infection I mentioned earlier. The third is to find out if the drug that they're taking has still measurable levels. So if you're developing neutralizing antibodies and the drug is getting cleared out of your body, those levels won't be detectable. The fourth would be then to consider dose changes, a short-term fix like a week of steroids, which we know we'd like to avoid but sometimes need, or whether we need to consider cycling to another drug within the same class. That's most often appropriate if the patient developed anti-drug antibodies to the first drug, meaning that those antibodies neutralized the first drug, but the mechanism was still working. And finally, we would consider switching therapies altogether, which we call swapping or changing the mechanism of our treatment strategy. So this general approach is how we approach patients when the therapy seems like it stopped working. Reminder to send your questions in because we're about to get to that part of the program. I only have a couple slides about cancer and ulcerative colitis. It's actually the area where I began all of my research when I was a young faculty member. And we recognize that patients with IBD are quite fearful of developing bowel cancer. And it used to be thought that because we didn't understand colon cancer and colitis, that we didn't have a way to do anything about it. But a lot has changed. So despite the fact that we recognize this is still something everyone fears, we now know that the risks can be defined and cancer of the bowel and colitis, in almost all cases, could be prevented. Let me tell you a little bit more. First of all, it's the inflammation that drives the colitis-related cancer. Just like any other part of the body, if it's chronically inflamed, it has a higher risk for malignant transformation. So one of the features we've now learned is that if you can control the inflammation over the time you have the disease, you are likely reducing the risk for cancer. The second is that we have very good optical technology with our newer colonoscopes, and most precancer and early stage cancers are very easily seen when we do what are called screening and surveillance colonoscopies. And when we find those lesions, we can either remove them during the colonoscopy or recommend surgery to make sure that we keep the patient well. It's important for you to know that the risk of colon cancer in colitis is only slightly higher than the general population now. It's not a sky-high risk that people should walk around fearful of. That doesn't mean, though, that you should ignore what you need to prevent it, and that's summarized on this slide. Regular surveillance colonoscopies looking for precancerous changes are recommended starting 8 years after you were first diagnosed, and in most cases, that's also when your symptoms started. We look for the dysplasia or precancerous changes, which can either be in polyps or flat lesions. And when we find them, if they are easily removed, then we can continue following. When they can't be easily removed, or if there's too many of them, or there are other risk factors that are contributing, then surgery may be necessary and is a very appropriate option in that situation. It's important to know that by being empowered with this knowledge and working with your healthcare team, you should have regular colonoscopies to make sure that you stay cancer-free. The intervals between your colonoscopies vary based on your risk factors, and you should talk to your healthcare team about those. So we finally reached the point where I can start answering some of your questions, and I'm grateful that you took the time to send them in. I'm sure that I'm not going to be able to answer all of your thoughtful questions tonight, but I hope that we've tried to address many of them in my program this evening so far. So the first question is the one that I often get when I'm in practice in my clinic, which is, what should I eat and what foods should I avoid? Of course, diet is a very important part of this. Any bowel disease clearly has diet as a contributing factor in some way. However, we haven't yet found a diet that clearly caused colitis, and we haven't found a diet yet that clearly heals colitis, despite whatever you read on the internet. We do know, however, that certain diets make symptoms worse, and symptoms and bowel inflammation, you've learned in this program, are not always the same thing. So certainly we recognize the importance of having certain dietary recommendations. Our general recommendation is to have what's called a low residue diet when you're actively flaring, and that's purely to reduce trauma on the inflamed bowel. Our general recommendation as well is to eat a less inflammatory type of diet. Now again, the evidence is not strong yet in this at all, but we're actively studying it. But I've been recommending a Mediterranean-style diet in general, which is healthy for your heart, your skin, as well as your bowel. We don't know that that can replace any of your therapies, but it certainly is a reasonable suggestion. The other things that can reduce inflammation, regular exercise, and very importantly, regular sleep. We've learned that your sleep actually becomes disordered when you're inflamed before you even know it and have a flare. And we're looking at ways we might use that as a marker to predict your risk of flaring. So there's many things you can start doing yourself and try to adjust your lifestyle in this regard. But I wish I could tell you about a diet that would put your bowel into remission. We just don't have it yet. Now, there's a few other things folks are asking about. One of them is based on CBD oil or cannabis-derived products or medical marijuana. And I want to say that there's a few things to know about regarding this. The first is that there's great interest in whether something called cannabinoid receptors are at all involved in inflammation of the bowel. And so far, although we know that marijuana and cannabis can reduce symptoms, we haven't yet shown that it turns off the inflammation. So in my own practice, I've been supportive of patients using this to control some of their symptoms in combination with an appropriate medical approach to their inflammation. In many states in the U.S. where medical marijuana is approved, it's approved for Crohn's disease, but not for ulcerative colitis, interestingly. In Illinois, where I live and work, the state of Illinois just modified their regulations and now allows it for ulcerative colitis as well. It is not a substitute for active anti-inflammatory treatments, but it can be useful for some situations. I want to recommend, though, that if you're having persistent symptoms, it would be important to know whether you're still inflamed and whether you need an adjustment in your other treatments. Let me look at a couple other questions here. There's a couple questions right in a row about pregnancy and what therapies are appropriate for pregnancy, and I appreciate that. As I started tonight, young people often are diagnosed with these conditions, and of course they're planning their families and their lives. Most of the therapies I listed are actually safe and have been studied during pregnancy. There are some exceptions. We prefer patients to not be on high doses of steroids in the first trimester. We can use steroids later if we really need them. The biological therapies that I've discussed tonight are actually not crossing the placenta until late in the pregnancy, and they've been studied extensively, and they do not affect fetal development, and there have not been any adverse events in the newborns followed into grade school. They're following the babies born to moms on these drugs. One of the drugs that's new, tofacitinib or Xeljanz, hasn't been studied enough in pregnant women, and so we haven't been using it in our patients who are pregnant. The most important message about pregnancy with colitis is that we want the colon to be in remission when you get pregnant, because the immune changes that occur with pregnancy can in fact activate the colitis if you're not under good control. So it's very important to stay on your medicines if they're working and to work with an informed obstetrician and gastroenterologist who are communicating with each other. Similarly, breastfeeding is safe with most of these therapies. We don't know enough about tofacitinib yet, but the other treatments can all be used in breastfeeding. So I hope that's helpful. The AGA has a wonderful website for women and men who are planning their families and want to learn more about IBD and how to manage it. So you can go to the American Gastroenterological Association's website to learn more about that. I'm going to answer one more question and then we're going to wrap. So there's a question here about depression and colitis. We've come to appreciate very much that having ulcerative colitis increases the likelihood that you may have anxiety or depression associated with the disease. And this is very important. We understand why a disease that affects your ability to function socially and may limit your ability to function can certainly be accompanied by depression or anxiety. I want to make sure that you're getting treated and that's being addressed properly. And I want to tell you about a little bit of new research that's very interesting. Although we thought that depression and anxiety might be related to colitis because of how colitis affects your life and being diagnosed with it might affect your life, we're now learning that it might also be related to the bacteria in the bowel and serotonin from that bacteria and how your bowel is responding to those bacteria, and the serotonin and other neurochemicals may be triggering the psychological comorbidities. It's very important to talk to your healthcare team and to see appropriate therapists to address these symptoms. And we're going to continue to work very hard to first, of course, make sure our colitis is treated properly and to screen our patients. In the new UC guidelines from the ACG, it is included that patients with ulcerative colitis should be screened for anxiety and depression. If you're feeling like you may have that, I want to encourage you, please, to call your healthcare providers, to talk to your family, and to get the help you might need. So with that, I'm going to segue into our last point tonight, which is how can you do all this? It's a lot of information. You may have been scribbling down a lot of notes tonight, and you might not be sure what to do next. So I'm going to try to summarize. The first is for you to know that there are some checklists available related to the prevention strategies we talked briefly about during this program. One of the checklists is available on the Crohn's and Colitis Foundation's website. It was recently updated, and it's an excellent way for you to know about vaccinations, monitoring, cancer prevention, and a variety of other things that you need to know and do to be proactive about your disease. The other checklist is through a nonprofit that I'm involved with called Cornerstones Health. And if you go to the website for Cornerstones Health, you'll also find our checklist related to what to do before you start therapy and how to monitor it, as well as vaccines and cancer prevention. So I encourage you to use checklists to help you get organized. Secondly is how you can make the most of your visits to your healthcare team, whether it's a physician or an advanced practice nurse or any other member of the team, like the very important components of our teamwork, like dietitians and psychologists, social workers, all the different people that work together to take care of IBD patients. Make a list, have an agenda, make sure that you're organized when you show up for your visit. Bring a family member or a close friend who can listen and take notes and remind you when you haven't mentioned something that was very important to you. There's a lot of things that you can do to be organized and to make the most of your time. Learn how to communicate effectively using the electronic portals and the other systems that exist so that you're not experiencing barriers in communication. And if you feel like you're in a system or seeing a physician who's not comfortable with your disease or managing colitis, it's okay to ask for other resources or to get a second opinion. There's a whole bunch of questions you might want to ask during your next visit, and I've compiled some of them here to summarize for you, and I'm not going to go through all of them, but you might want to know, how active is your disease right now? If you're feeling well, are you one of those folks who still has inflammation of the bowel if you looked with a scope or got a stool test? What is the extent of your disease? How much of your large intestine has been involved? What is your prognosis or your risk for having surgery in the future? Are you still on steroids, and how can you get off? When are you due for your first screening for colon cancer prevention? And if you're already getting screened, when are you due for your next exam? And is that interval appropriate for how your disease is functioning? There's many questions you should ask, and once you have these answers, I'm sure it'll provide you with more comfort in knowing how to manage your disease rather than having the disease manage you. I'm grateful for the opportunity to have had this conversation tonight. I'm sure there are many good questions that I couldn't get to, and I'm sorry about that. But I want to thank CME Outfitters for organizing this program, and I would refer you to their website so you can see some of the content from this program as well as other patient materials. The website is cmeoutfitters.com/gastrohubpt. PT stands for patient. So gastrohubpt. I also want to tell you about an exciting program that's coming up in December. It'll be similar to this one, but on Crohn's disease. And I'm delighted that I'll be joined by my good friend and expert colleague, Dr. Bruce Sands, who's from the Mount Sinai Hospital in New York City. Bruce Sands was one of the authors of the new Crohn's guidelines that were published last year by the ACG. And it'll have a similar format to tonight, although we'll be speaking together and you'll hear from Dr. Sands as well. So I hope you'll mark your calendars. If you have Crohn's and you logged on tonight to hear about ulcerative colitis, well, that program will be for you. And some of the similar principles we discussed tonight about colitis will certainly apply to Crohn's. If you know somebody who has Crohn's, encourage them to join us on December 12th. I look forward to follow-up, and I hope we can do more programs like this in the future. Thank you very much.